Hi, everybody, and welcome to a Prasiska GI cancer-focused tumor board. My name is Sam Klepner. I'm a GI medical oncologist at Massachusetts General Hospital in Boston, and I'll go around as I see it on my screen. So I'll start with Dr. Siegel.
Good afternoon. My name is Carrie Siegel. I'm an abdominal radiologist at the Mallinckrodt Institute of Radiology at Washington University in St. Louis.
Hi, everyone. I'm Pritesh Patel. I'm an associate professor of radiation oncology at the Winship Cancer Institute at Emory University in Atlanta.
Hi, I'm Marty Weiser. I'm a colorectal surgical oncologist at Memorial Sloan Kettering Cancer Center in New York.
Hi, I'm Al Benson, and I'm a GI medical oncologist at Northwestern University in Chicago.
A 60-year-old woman with progressive dysphagia who was found to have a clinical T3N0M0 stage 3 lower esophageal adeno, which was HER2 and PDL1 negative. Patient received neoadjuvant chemoradiation followed by a transhiatal esophagogastrectomy. And the topic for the discussion is adjuvant therapy. So I'll walk us through the case very briefly. Again, these are real cases that were submitted. So this is a patient presented with dysphagia, about 6 months history with a preserved performance status of ECOG 1, very typical presentation. Medical history includes a lupus anticoagulant syndrome on chronic rivaroxaban, hyperlipidemia, known gastroesophageal reflux, and asthma. Social history is notable for no smoking, alcohol, or drug use. Patient is married and retired, and no family history of GI cancers, but a history of melanoma in the family. So this is the early presentation in January 2019 with an upper GI endoscopy showing a biopsy from an ulcerating mass in the lower third at 34 to 39 centimeters from the incisors with partial obstruction. Biopsy with adenocarcinoma, again, negative HER2 and PDL1. And here is a key image from the pre-treatment staging, and I'll just ask Dr. Siegel if there's anything you want to comment on this image snapshot.
I'm just going to comment on this single image that there's really marked thickening of the distal esophagus. It doesn't look like a hiatal hernia where there's gastric folds that are up in the distal esophagus. This looks like a mass with really coaptation of the lumen and marked esophageal wall thickening.
Great, thank you. And here's a subsequent staging PET scan confirming what you described. Patient started on neoadjuvant chemoradiation to 50.4 gray over 28 fractions with concurrent carboplatin and paclitaxel per the cross trial with the more US common radiation dosing. I'll continue through the history. So patient completed chemoradiation with grade 3 thrombocytopenia, requiring chemotherapy to be held, doses number 4 and 5. So received 3 of the planned 5 doses with concurrent radiation. There's a restaging PET scan that reveals no evidence of progression, and the patient is taken for a curative intent surgery, which reveals a YP-T3N1 M0 tumor with 2 of 18 nodes and negative margins. So Dr. Weiser, I don't know if you want to comment at all on the surgery. This is pretty typical experience in our practice.
Yes, there are different ways to approach esophageal cancer, including a transhiatal, which is operated through the stomach, through the abdomen, and a neck incision. There's also the Ivor-Lewis, which is operating through the chest and the abdomen. And of course, the 3-site or 3-hole esophagectomy, which includes the abdominal approach, chest approach, and neck approach. And the thoracic surgeons fight over which is best, but most of the data shows that they're similar. You can do a more complete lymphadenectomy generally if you enter the chest, and many will argue that that's a better approach. In the Ivor-Lewis approach, where you enter the chest and the abdomen, the anastomosis is in the chest, and that is associated with slightly higher morbidity from an anastomotic leak. But I would say that this is a very reasonable approach for this tumor.
Yeah, now I'll ask Dr. Patel while we're here, maybe briefly cover your thoughts on the 4140 versus 50.4 dosing that was used to treat this patient.
Yeah, I think sort of remains an open question. The cross trial, as you mentioned, big randomized trial that showed that the chemo and radiation prior to surgery does improve survival. That modern trial used 41.4 gray, and the standard practice in the U.S. Really has been to give the dose you see here, 50.4 gray. In our practice, we tend to use both, but we also tend to lean more towards 50.4 gray, just sort of a historical precedent here. No really level 1 data to sort of support one or the other. I think both would be considered standards. In general, we think maybe squamous cell cancers are maybe a little more radiosensitive, sometimes making the case for a lower dose. For example, if a radiation oncologist is struggling with some of the normal tissue exposures, a very large tumor, and you're running into trouble with heart and lung exposure, which is what we worry about with radiation, you have the flexibility maybe to decrease the dose down to 41.4 gray in a situation like this, where you might feel better about avoiding normal structures and reducing surgical morbidity. So, I think we're really using both sort of interchangeably, but in terms of cancer outcomes, there aren't any data really to show a difference yet.
Yeah, I would agree. Our practice institutionally has generally been 50.4 in the absence of reasons to consider potentially lower doses. And now I'm going to get to Dr. Benson, because this is really the key question that the provider is asking is, one, what adjuvant therapy would be recommended, if any, and how do you think about adjuvant therapy? Maybe comment on the newest checkmate data here.
Yeah, so I would add that it's very disappointing that the patient did not appear to have tumor regression. One of the advantages of neoadjuvant therapy is we hope to see, for example, chemotherapy sensitivity. We hope to see regression. And so that is of concern and could weigh in terms of a strategy. But as you mentioned, recently reported in the New England Journal were the results of the adjuvant trial, which evaluated post-operative nivolumab versus observation for patients who had received neoadjuvant therapy. And what's interesting about this trial, which is somewhat in contradistinction to what we've seen with metastatic disease and, for example, CPS, and linking such to the benefits of immunotherapy. In this trial, PDL1 was tested, but it appeared that the advantage of nivolumab versus observation was seen regardless of PDL1 status. And these results were quite impressive, and I think now represent a standard of care for these individuals who have received neoadjuvant therapy. And just like the trial, these patients, although had stage 2 and 3 disease, all had to have evidence of residual disease by pathologic determination after surgery. So I think that nivolumab would be a very appropriate regimen. I think many of our patients tolerate single agent immune therapy well in this setting. We know it's not always easy treating this group of patients in the adjuvant setting because the chemoradiation is, of course, not always easy. In fact, this patient had to miss some doses of chemotherapy and then a major surgery. But I think in this case, nivolumab, after appropriate recovery, perhaps up to 10 or more weeks would be a good strategy for her.
Yeah, I would agree, and I'll ask one question. You know, in the study, patients had to have CT evidence of no early or progressive metastatic disease prior to randomization, and I think it was allowed up to 16 weeks post-op. So maybe Dr. Siegel, you can comment on sort of equivocal post-op findings, and are there ways to adjudicate these? We always struggle with this when we scan patients, you know, 10 or 12 weeks after surgery.
Sometimes it can be difficult when you see small lymph nodes or little areas of thickening at the anastomosis. I think that things that are going to help us the best are going to be a follow-up study to see whether these are resolving, and occasionally PET imaging. Obviously, if people have a complicated postoperative course and an infection, some of the lymph nodes might be infectious or inflammatory in etiology. But usually between a PET and two postoperative scans, we can clarify some of these findings.
Yeah, it's very similar approach that we take as well. And, you know, I think in the future, there's a space where perhaps some of these minimal residual disease assays and molecular testing may help us further stratify this patient population, but that's still a research topic largely.